Thanks for the introduction. Yes, I'm an academic GP and I've recently joined the Centre for Academic Primary Care in Bristol, just across the water from you. And I'm really sorry I'm not able to be there in person. Bristol's hosting the Society for Academic Primary Care conference starting tomorrow, so I couldn't get away any more this week. What I wanted to talk to you about really was just this website which I developed and was released last year, which I hope will give you something new and useful to support you in your practice. It's especially nice to be speaking to you in Wales. When I had the seed of this idea about 10 years ago, I got very interested and slightly involved in the prudent healthcare movement, which was starting over in Wales, and was really impressed and inspired by the polypharmacy work that was happening in Wales and also in Scotland. So it's nice to be able to return to show you something in return, if you like. So the website's called GP Evidence, and the strapline of it is just summaries of the evidence on the benefits and harms of treatments for long-term conditions, and it has that simple job to do. And the idea for the development of it came to me as a GP in practice, realizing that this kind of information wasn't really available to us. So I hope it will fill a gap in the information and evidence architecture that you already have. I'll just do a quick declarations of interest slide. I'm a salaried NHS GP working in Oxford clinically at the moment. The research, the funding for the research and the development of GP evidence all came from the National Institute for Health Research. The evidence exists as a non-commercial entity and is not profit-making. The intellectual property for it is held by the University of Oxford under a standard NIHR contract. So I'm not here to sell you anything. And you've already heard about some other roles I have. So just to go back, I want to say a bit about why I got into this field and why I became an academic GP, and the problem I hope this website will solve. So I've been a GP for ages, and over the 2000s, I was a partner in a practice and was running a cardiovascular prevention clinic. And we were a really proactive practice and had clinics set up for diabetes and cardiovascular disease and respiratory disorders, much like most people have nowadays. The early ideas of evidence-based medicine ended up turning over that decade, I think, into what one might call guideline-driven practice. And there's a lot that's positive about clinical guidelines and what they do, how they encourage the dissemination of good evidence-based healthcare and simplify the evidence for us. And I was really enthusiastic about that over that decade. But as time went on, I began to feel more worried about the amount of polypharmacy that was happening. I was spending a lot of time dealing with side effects and complications of medicine, and began to wonder just how valuable all of this really was. And one of the things I did after a while was start to look at the evidence behind clinical guideline recommendations, and was surprised and a bit alarmed to discover that there's a huge range of effect within the treatments that are recommended in clinical guidelines, thinking about numbers needed to treat or absolute risk reduction that a patient might expect to get. So if we're prescribing a statin, an aspirin, a glucose-lowering drug for diabetes, and we're doing that to prevent some future possible harmful outcome, like a heart attack or a fractured hip or a stroke or whatever it is, the size of the benefit of many of those treatments is really small. Sometimes it's pretty big, and it's very hard to tell the difference. And if you try to find that out, it was almost impossible, I discovered. You have to end up rooting around in huge documents at the back end of guidelines or looking at scientific papers, all of which is too time consuming to do and really confusing when you find it. So I had this idea, well, wouldn't it be great if there was a website that just gave you all this information nice and easily? How hard could that be? And that led to several years of work and a career change into academia to develop this website. Just a little bit about how it was developed. What I thought would be an easy idea turned out not to be for a number of reasons. Firstly, there's some complicated evidence you've got to pick through and interpret and then figure out how to present it. But there are also a lot of user problems. So how to make this complicated information quick and easy to understand because we're all short of time. How do we get over the problem that we're all, most of us, are not very confident with statistics, with the terminology of scientific papers, and how do we teach that? How do we communicate it? And there's a tension between providing simple information, which is easily digestible, but may not be nuanced enough, and providing complex information, which may have all the detail, but is too complicated for anybody to even to read. So to get over that, the website was developed using a participatory co-design process where GPs and patients had input into the design process all the way through to make it as user-friendly as possible. And I'll show you the website in just a minute. It gives us data, it gives us some numbers and some written information about clinical evidence behind the guidelines. And all of that is supposed to sit within the context of shared decision-making, which I'm sure you know all about. It's an easy enough concept, but often misunderstood. And I'm just going to sow the seeds before I show you the website with a couple of definitions from different people about what shared decision-making is. And we may come back to this at the end. So the NICE guideline for shared decision-making says it's a collaborative process that involves a person and their healthcare professional working together to reach a joint decision about care. There's another definition from the NHS England Personalised Care Institute, which says that shared decision-making supports people to understand their options and gives them the opportunity to consider relevant information that might influence their choice. I think the notable thing about both of these definitions is that they're both quite soft and they're both a little bit woolly, and that's deliberate. I'm sure these sentences were very carefully crafted after a lot of thought. Shared decision-making can be a different thing for different people in different contexts. And it's not just about getting some numbers and giving them to people and telling them to go away and make their own mind up. It's about a collaborative process between clinician and patient. And the data I'm going to show you on this website is designed to support that. The website's designed to give information to clinicians. It's called GP Evidence and was designed with GPs, but there's been huge interest from primary care pharmacists about this, which has been really nice, and it seems to be as useful for them as GPs. I just want to emphasize that the information there is for you to kind of see and think about and use as you wish. You may not share numbers with patients, you may not share data, or you might choose to. So with that in mind, I'm going to switch my screen share and just show you around the website a bit so you've got some idea about what's on there, and then we'll be able to do some Q&A afterwards. Okay, so you can see that's up there. So GP Evidence, the address is gpevidence.org. If you are tempted to look while I'm speaking, don't do it on a smartphone because it doesn't deal well with the small screens, but you need a laptop or a browser. It's free to access, no sign-ins or barriers of any kind, and it's open to the public as well, obviously. At the moment, we've got 12 long-term conditions, which are in a menu down the side here, and they're the sort of big hitters in terms of long-term prescribing for chronic conditions. So atrial fibrillation, CHD, CKD, etc., hypertension, heart failure, menopause, osteoporosis, stroke, and diabetes. We'll start with statins because it's a classic shared decision-making consultation, and the data about statins is in many ways the simplest and easiest to think about. So we go to the lipids section. You'll see there's not much text on here. There's very little in the way of underlying information about conditions because it assumes that you know that already, so it's uncluttered with information you don't need to read. So we have a treatment page and then a list of a condition page, sorry, and a list of possible treatments. We've got statins and also going down to the new fancy lipid-lowering drugs as well. So if we open up statins, there's a little bit of an introduction here saying the risk reduction for an individual depends on their baseline cardiovascular risk, and you will be used to the idea of Q-risk tools to predict someone's 10-year risk of having a cardiovascular event, and then that determines maybe whether or not they will have a statin. And the NICE guideline says you can offer a statin at a Q-risk of 10% or higher. So you see a drop-down menu here, which gives you an option for a Q-risk score that you can enter once you've got it for your patient. And let's start off with somebody who's at high cardiovascular risk, say 30%. So as I said before, one of the jobs the website had to do was to make the results of clinical trials and systematic reviews understandable. And so it presents this basic information in 5 different ways to suit whatever your preference is. And the infographic is probably the most popular thing that we discovered when we're doing research on GPs in terms of communicating this evidence. So you have a window over here, 100 people over 10 years not taking a statin if they have a baseline risk of 30%, and 30 people have a cardiovascular event of 10 years. Over here on the right, the same 100 people, or 100 people like them with treatment. You can see that 19 people who are the yellow smiley faces have a cardiovascular event prevented because they took a statin for 10 years. 70 people, of course, who are never going to have the cardiovascular event don't have it. And 19 people do have a cardiovascular event despite taking a statin. Sorry, that's 11 people have one prevented. You can express that information in a number of ways. You can say there's an absolute risk reduction of 11%. That's the yellow smiley faces. The number needed to treat of 9. That means how many people have to take a statin for 10 years to have one event prevented. Or you can have a relative risk reduction, which is always the bigger number, which is what proportion of those people who are destined to have a cardiovascular event don't have one. And so that's a bigger number, that's 37%, just over a third of them. There's a little pop-up box here that will explain the statistics for you if you want to have a look. And then finally, there's a plain language summary at the bottom. If 100 people with a baseline 10-year risk of cardiovascular disease of 30% take a statin for 10 years, 11 will avoid a cardiovascular event compared with if they hadn't taken a statin. And when I did the user testing on this, lots of GPs were saying, oh, this is great, I could just read that out to a patient. And you could show them these graphics as well if you want to, but just be mindful that this was not user tested with patients as a patient-facing decision aid. It's there for clinicians, and you need to provide with a supportive conversation around it if you're going to be showing this to patients. So this is how the basic data is presented, and underneath there's some other pop-up boxes with more information for you to dig in deeper if you want to. There's a bit about where the evidence came from. This was from a NICE evidence review. Most of the data here does come from the evidence reviews that NICE did to develop their guideline. Where that information wasn't available, I've gone to Cochrane reviews and other trustworthy systematic reviews. There's a bit about evidence quality here. So if you explore the website, you'll find there's quite a range of evidence quality for stuff that we do every day. It ranges from low to high mostly. There's a bit of explanation about the quality of the evidence here. And elsewhere on the website, it talks a bit more about how that's determined. The short version is that quite a lot of evidence is actually low quality in the official rating scale, but that doesn't mean it's worthless. It just means there's a bit more give and take around the certainty about the figures you're seeing. There's also a button everywhere under the data for study population, which tells you a bit about the people who are in the clinical trials, because they might be very different from the patient who's sitting in front of you. And then you have to use your clinical judgment a bit to think about how applicable it is to them. The rule of thumb is probably that it's mostly fairly applicable, but you might need to think about it. Some other pop-ups underneath that vary from screen to screen. Here we've got some stuff about high versus low dose statins, statins in older people, for example. I'll just show you another site just to show you some other things that can happen. Say if we take osteoporosis, we look at bisphosphonates, and you might have a FRAX or a Q fracture score for somebody's fracture risk, and you're saying, do you want to take a alendronate for this? You can put in their 10-year fracture risk. But in this situation, you might want to think about different outcomes. So a FRAX score will give you a risk for all osteoporotic fractures. So say you have a 20% fracture risk here. But it will also give you a risk score for a hip fracture. Now, because hip fractures are a bit rarer, let me just reduce that. If the hip fracture is the thing you're interested in preventing, the numbers can change quite dramatically. So you have the same relative risk reduction of 33% in fracture risk that alendronate will give you over 10 years. But because the hip fractures were rarer, the absolute benefit might be quite small. So here, only 2 people out of 100 will have a fracture prevented. If all 100 of them take an alendronate fracture prevention at that level of risk. And you can see down here that the evidence is moderate or very low, and there's a bit more information there you can look at and read to unpack it. Sometimes you might also think, well, what does something like all osteoporotic fractures mean? What kind of fractures are those? So there's a pop-up button here that will unpack that and give you a breakdown of what all osteoporotic fractures mean. The short answer is it means all fractures. They just call them osteoporotic fractures. And the majority of them are actually subclinical vertebral fractures that are small vertebral deformities that are not symptomatic, but may over time cause problems. I'm coming to the end of this 20 minutes talk, so I'll just leave it there, apart from to highlight the section up here, which talks about some important concepts that are useful to know if you're using this information. So how do you apply this evidence, which comes from clinical trials, to individual patients? How do you understand evidence quality? How can you think about evidence in context of multimorbidity and polypharmacy? Because it's all single conditions, all the research is on single drugs. And most of the time we're dealing with people with greater complexities. The short answer is there's no easy answer, but there are some pointers in there, but it's a matter of accumulating all this information about single treatments and trying to bring it together in the best way you can for the patient. Shared decision-making, there are consultation skills and lots of things to understand about shared decision-making. And there's a summary there and some links to some really good educational resources on that. And finally, there's some blurb about medical legal considerations. One of the great barriers to practicing in this way and practicing shared decision-making is that maybe you're not going to go with a guideline recommendation, and that makes us nervous, and we might feel vulnerable about being, medical legally culpable, whatever. The short answer is that you're not, and it's actually very safe to practice shared decision-making and deviate where appropriate from guideline recommendations. But there's some very sort of short, I hope easy to read, brief things to look at there, which I'll encourage you to have a look at. And there's also a feedback if you want to get in touch or make any comments or criticism or anything about the website, you can do that directly via the website. So I'll stop talking and happy to take some questions. I'll leave the website up there because I might show you around it to respond to some questions. Thank you.
Thank you very much, Julian. Fascinating resource. I was just going to ask you talk about adherence today. Have you got any data on use of the software and effect on adherence?
Sorry, the sound was breaking up there. I couldn't quite make out the last bit of that.
I wonder if you had any data on the use of this website and its effect on adherence.
No, nothing yet. It only came out last year. We've got just a short evaluation study looking at GPs' understanding of it. The plans for the next stages of research are to think about how it's really used in practice. So we're hoping to get some interested GPs to trial it in practice and then feedback about how it affected their decisions and their decision making. I'm not sure it would be possible to prove increased adherence with this, just because the nature of how it will be used, I think, because the decisions that I think it will encourage will be quite scattered over time. It's something that will be used every now and then for some people, some of the time, and I think it would be quite hard to create a population of people on whom it had been used repeatedly enough to gather data on their adherence. But you would think that if people had better shared decision making and consultations at the beginning, then their adherence would be better. There's research on shared decision making in general that supports that, but nothing for this website, I'm afraid.
And then the only other thing I was going to ask was one of the problems you have with these types of information, which was very clear, is just keeping it up to date and relevant with terms of new evidence and new treatments. Have you got a team to help you with that?
No team yet. If someone wants to fund one, that would be great. So because of that, actually, the ambition or the plan is to keep it as up to date as NICE guidelines. So whenever there's a NICE guideline refresh, the evidence will be refreshed on here. Historically, NICE guidelines have been slow to update, but NICE have changed the way they've worked in the last couple of years, and we're going to see smaller, more frequent changes happening. So that will be positive. But it won't be, I'm not searching for the latest trial that's come out and getting it on there quickly. There are hazards to doing that as well, because really to get trustworthy evidence, you've got to have a good systematic review process, and I think a committee reflection process as well. And jumping on the latest trial that's getting advertised or promoted can often be misleading.
So you've got your work cut out as well for the future. We'll just go to the audience now and see if there's any questions. Well, I think you've sold GP. Oh, sorry.
Expand upon the legal implications of the shared. If you make a shared decision, you don't exactly follow a specific guideline. What the implications are, how driven we are by these guidelines.
I don't know whether anyone's able to repeat that. I got the gist.
Look at the how this software impacts medical legally if you deviate from the guidance. So just a bit more about that to clarify the statement. Is that correct?
Yeah, it's a really good question, and it's the number one that came up with GP users. We have this idea, I think, because of how guidelines have evolved in our professional culture, that we should follow them. And if there's a guideline recommendation there, we should do it, and we're in trouble if we're not. In actual fact, that's never what guidelines were intended to do. And it says that at the top of every NICE guideline, that they're supposed to be used alongside clinical judgment and taking into account the values and preferences of your patients. The General Medical Council says the same thing. The medico-legal bodies say the same thing. The Royal College of GPs, when they talk about multimorbidity, personalised care, say the same thing, and NHS England says the same thing. So everywhere it is accepted that best medical practice involves shared decision making. That's including medico legally. The Montgomery judgment actually strengthened the case for shared decision making. Have a look at the article I wrote on this website for it. During the process of developing that, I was able to talk to a couple of really senior medico legal experts who work for the NHS, who told me that, to their knowledge, no one in primary care to date has actually been successfully sued for not following a guideline. So that we have a greater fear of medical legal consequences than it is in fact real. That doesn't mean guidelines can be ignored. You do have to take them into account. And if you're choosing not to follow a guideline recommendation, it does need to be documented that you've made that decision and some description of why it was made and that was shared as appropriate with the patient. That doesn't have to be writing a big essay, incidentally. So the law is on our side for this, and I can't emphasize that strongly enough. But it's a really common reaction people have.
Thank you.
Hi, my name is Ellie. I'm a practice pharmacist. Did I see that you've got shared decision making evidence of stopping treatment? If only did a starting step, it can be quite difficult to encourage people to stop at any point.
So I think that was the difficulty of stopping treatment rather than starting it. Is that correct?
That's correct, yeah.
Yeah, it's really hard. So there is basically no randomized control trial evidence for most of these things about what happens when you stop, a statin or, stop any of the treatment, in somebody who's, say, elderly, and you think, well, do they still need it? So it's a really difficult problem because it's evidence-free. Psychologically, for all of us, it's much, including myself, it's much harder to stop a drug than to choose not to begin it. How I practice with this is I use the data that is on GP evidence, which is about stopping, and that gives me some idea of the benefits that accrue over time from a particular treatment. So particularly with somebody elderly, you could look at, say, the evidence that is projected for 10 years, and you might say, well, there's a 6% risk reduction over 10 years in somebody in their 60s who the clinical trials are on. And I've got a frail 85-year-old who I think, might not be around in 2-3 years' time. And then you can think to yourself, well, what's the amount of risk I'm likely to be conferring if this treatment is stopped? And you could do a, in your head calculation that it might just be 1 or 2%. And that, I think that would be a reasonable way to think about things. That's how I think about things. And build that into your conversations. So the information there can help frame those decisions, but we haven't got hard data to support it. It's really difficult. There's a section in the applying the evidence to individual patients and in the multimorbidity and polypharmacy bit at the top of the website there, which talks a bit more about this, if you want to have a look at that.
That's excellent. Well, Julian, thank you so much for your time today. I think this is a great development and wonderful that you've taken it on, and surely many people here would want to get involved and use this site. And I presume also if you're looking at trials, maybe some people in this room who wish to be able to assist you in some way. So sure some people will be in contact. Thank you very much.
Yeah, please do anyone get in touch if you're interested in engaging in any way at all. That'd be fantastic.